This presentation tonight is just going to be, I guess, a bit of an overview as to all the different ways we can kind of detect and look at inflammation on our CBC and our biochemistry panels, with a particular focus on the leukogram and measurement of acute phase proteins. So first thing I'm going to cover is leukogram patterns in inflammation and some other sort of non-inflammatory leukogram patterns that you might come across. Monitoring leukogram changes over time as a way of monitoring inflammation. Species-specific differences to keep in mind when interpreting your leukograms, as well as just briefly going over some other CBC and biochemistry changes that you can see within with inflammatory disease. And then finally finishing on acute phase proteins and their use in veterinary species, with a particular focus on serum amyloid A and C-reactive protein. So I guess starting off with our basics, so the neutrophils are sort of the main cell that we look at when we're looking at inflammation in our leukogram. And their half-life in blood is approximately 5 to 10 hours. And in the bone marrow, there's a proliferating pool and a storage pool of our neutrophils and other leukocytes. So when you have your initial inflammatory stimulus, you get neutrophils released from this storage pool immediately, and this can cause neutrophil counts to rise in blood in the short term, depending on what species you're dealing with, while bone marrow production then starts to increase to meet the peripheral demand. So neutrophil maturation takes around about 3 to 5 days. And there is some species variation in maturation time. So for example, in horses, it can take around 7 to 9 days for that to happen. But maturation time can be shortened with intense inflammatory stimuli. But basically just the main point is that bone marrow production or increasing bone marrow production does take some time to occur. So when we think of our, I guess, classic inflammatory leukogram, the main thing that I guess we typically expect to see would be a neutrophilia plus or minus left shift toxic change, and we may see a monocytosis as well. But with inflammation, your neutrophil count can really be anywhere. So you could have neutropenia, or your neutrophil count could even be within a reference interval technically. So the two major factors that are sort of governing where your neutrophil count ends up is how fast or how many neutrophils is your bone marrow producing, and then how much demand for neutrophils is there at the site of your inflammation. So how many neutrophils are being drawn into peripheral tissues. And this inflammatory leukogram is kind of non-specific to cause. So it tells you that there is inflammation, but it doesn't tell you the underlying reason. If you have extreme neutrophilias, so even leukocyte counts above 50, probably more commonly you would expect to see neutrophil counts of that magnitude in small animals, but sequestered purulent inflammation would be what you would consider with those. So pneumonia, prostatitis, peritonitis, pyometra, and pleuritis, just to name a few. And then just other things to keep in mind when you're looking at neutropenia is that this can indicate overwhelming or acute inflammation, but non-inflammatory causes of neutropenia can be present, so including bone marrow disease or even immune-mediated destruction. And actually, that's another part where acute phase proteins could be useful in those scenarios. So a couple other leukogram patterns just to be mindful of and to not confuse for inflammation. Probably the main one to not confuse would be a physiological or epinephrine leukogram, so which is I guess related to kind of a fight or flight response. It's not very common, but it is something to keep in mind, particularly in cats and young horses. So it's a very rapid response. It happens within minutes and then disappears. You know, like if you had a physiological leukogram or leukocytosis, if you repeated bloods in that animal like an hour later, you wouldn't see it anymore. And how this develops is in the blood vessels, we have a circulating and a marginating leukocyte pool. So your circulating leukocytes or neutrophils, they're the ones that are sort of in the flow in the center of the blood vessel, and those are what you pick up when you take your blood sample. Your marginating neutrophils are rolling along the edge of the blood vessel, and because they're sort of more on the edge, you're not going to sample them under normal conditions when you take a blood sample. But in response to epinephrine or adrenaline, the leukocytes get redistributed from this marginating pool into the circulating pool. So suddenly kind of all of your neutrophils or leukocytes are in that central area, and they're able to be sampled when you take a blood sample. So it's not that you have more leukocytes in total, it's just that they're all being, it's a redistribution more than an increase in total leukocytes. And the pattern you would tend to see is a neutrophilia as well as a lymphocytosis. You can see a neutrophilia and lymphocytosis with kind of more, I guess, chronic inflammation or antigenic stimulation, but it's pretty uncommon to see that. The next, and probably people more familiar with this, is a glucocorticoid or stress leukogram, which typically you would see with a neutrophilia, a monocytosis, and a lymphopenia. The neutrophilia predominantly develops because glucocorticoids prevent neutrophils from migrating out of blood vessels. So because neutrophils are present in the circulation for a longer period of time, you get higher numbers accumulating. And steroids are thought to, they can slightly increase bone marrow production as well. So there is a slight increase in production that can occur. With a glucocorticoid stress leukogram, the lymphopenia is the most consistent finding and will persist for as long as there is a glucocorticoid excess. The neutrophil count will often gradually decrease over time. So really, when we look to see a glucocorticoid stress leukogram, we really want to see a lymphopenia. So moving on to, I guess, morphological changes. So a left shift is a marker of inflammation in our leukogram and indicates the presence of immature neutrophils in circulation, and basically reflects an early release of neutrophils from our bone marrow storage pool. So we can split left shifts into what we call degenerative or regenerative left shifts. And what people call a degenerative left shift is somewhat subjective. Well, it's some people, the definition isn't completely standardized. But probably the most common definition is that when you have more band neutrophils than mature segmented neutrophils, that's what we would define as a degenerative left shift. But I just want to show an example that kind of shows that that definition isn't, I guess, hard and fast. So these are just two leukograms of two different patients with inflammatory disease. And if we use the definition that a degenerative left shift means we have more immature neutrophils than mature neutrophils, we would say patient 2 has a degenerative left shift, but patient 1 doesn't. But that doesn't, I guess, when we think about what leukogram is more concerning, even though, even though patient 1 doesn't technically have a degenerative left shift, I would still say that patient 1 probably has the most concerning leukogram picture. So because we have an overall leukopenia and neutropenia, that suggests that we have very significant tissue draw demand for neutrophils somewhere in the body, and that at that point in time, the bone marrow is unable to meet the peripheral demand for neutrophils. At least in patient 2, there are more immature band neutrophils than mature neutrophils, but at least the neutrophil count is high, which suggests that there's maybe more of a bone marrow response. Now, neither of these leukograms are good, or they both suggest that there's very serious inflammation going on. But just to kind of make the point that when you're looking at left shifts, the total leukocyte count can be is an important thing to look at. So toxic change is another morphological change that we look at to look for evidence of inflammation in our leukogram. It's another sign of immaturity in our neutrophils, but it indicates a slightly different process to a left shift. So a left shift is when neutrophils are maturing at a normal rate, but they're just released into circulation before they're quite fully mature. Toxic change is when neutrophils are maturing through the bone marrow at a faster rate than normal. And that is generally because there is such an intense demand for neutrophils. So if you have a toxic change, that usually signifies quite significant or intense inflammation, and more so than if you just have a left shift alone. So it's relatively common to have a left shift without toxic change, but usually if you have a toxic change, you have some degree of a left shift present as well. It's referred to as toxic change because originally it was thought to be associated with bacterial infection and endotoxin production. But basically any process that causes stimulation or intense stimulation of neutrophil production can lead to the presence of toxic change. So infectious and non-infectious etiologies can cause it. And so if we're looking at sort of, if we have a neutropenia, a degenerative left shift, and 3+ toxic change, they're sort of the 3 signs that you have really, really severe and overwhelming inflammation. And that's where alarm bells really start going off for me. These are just some pictures of some toxic change. So toxic change really needs blood film evaluation to detect, and it is a bit of a subjective assessment. So on the left we have a normal neutrophil, and then our other pictures are sort of just the changes we see. So the major forms of toxic change that we tend to see are a foamy and basophilic cytoplasm. So the cytoplasm here is a bit more blue or basophilic, and then we have these sort of irregular clear areas through here, which are our kind of foamy cytoplasm. These little sort of irregular blue structures in the cytoplasm, these are our Dolly bodies, which are our kind of 3rd sign of toxic change. Toxic granulation, so these sort of pink granules, that is a form of toxic change that you'll most commonly see in horses and cattle. It's pretty rare to see in dogs and cats. And this isn't strictly a form of toxic change, but just to be aware that giant neutrophils, these are another abnormality that you can see associated with intense inflammation, and this is most commonly seen in cats. And then the other thing I just want to touch on is pseudotoxic change. So this can occur, this is a storage-related change that can occur within a few hours, particularly if samples are left at room temperature. So if you leave blood to sit at room temperature, you can start to see some cytoplasmic vacuolation, and you can even see some faint blue structures that look very similar to Dolly bodies. So changes seen in stored blood can kind of mimic the changes that you can see in toxic change. And so the best way to avoid this is to make a fresh blood film at the time of blood collection, so that you're avoiding any potential artifacts or anything that might confuse the picture. Okay, so, and just a couple other changes to keep in mind, changes that aren't toxic change, but you could potentially confuse for it. Burman cats, as a breed, can have pink granules in their neutrophil cytoplasm. It's thought to be an inherited condition and is not associated with illness or clinical issues. So if you see kind of pink granules and in the neutrophils and it's a Burman cat, it's probably going to be just a normal or a breed-related change. And then another thing to keep in mind is foals can have pink cytoplasmic granules in their neutrophils up to around 30 days after birth. And these granules look very similar to the granules you'll see in toxic granulation. So if you don't have any other evidence of inflammation or other forms of toxic change, no neutrophilia, no left shift, your acute phase proteins aren't increased in the blood of a foal, just be mindful to not overinterpret the presence of these granules. So this is just a very basic diagram just to sort of visualize how monitoring leukogram changes over time can be a lot more helpful than just taking a single leukogram. So it can be hard to judge the extent of your inflammation if you're just looking at a single leukogram. Again, kind of everything goes back to the clinical picture and take care to treat your patient and not the numbers. But this is just sort of a basic graph that shows what can happen to a white cell count during an inflammatory response. And definitely not all responses are going to look like this, but basically these 3 stars show different time points where the white cell count is the same, but they're occurring at different time points in the inflammatory process. So, if you have a leukocyte count of whatever it is, and there is inflammation, is your leukocyte count on the way up because you have a good bone marrow response and you're getting on top of that inflammation? Or is your neutrophil count decreasing, either because, maybe your inflammation is resolving, or is your peripheral demand for neutrophils starting to overwhelm the bone marrow's ability to produce neutrophils? So taking these serial measurements over time, they can kind of help you fill in the gaps and let you know where you are in the time course that inflammation is occurring. Acute phase proteins also can really help with monitoring inflammation over time in our veterinary patients, and I'll talk about this later on as well. So what to look for with serial CBCs, or what you're looking for to indicate an improvement in the inflammatory picture of your patient. So an increasing leukocytosis or neutrophilia can suggest an improved bone marrow response. And in a similar vein, like a resolution of a neutrophilia or resolution of a neutropenia can also suggest an improved inflammatory picture. But again, just keep in mind the resolution of a neutrophilia can be a little bit dangerous. So what the patient looks like clinically is really important in that aspect, because again, has that neutrophil count normalized because the patient is better, or is tissue demand starting to outpace marrow production? A decrease in the degree of your left shift and a decrease in the amount of toxic change in your neutrophils. Those are also signs that maybe your inflammatory picture is improving. And I guess just to note that when you're evaluating a left shift in the presence of toxic change, that's really, you really need a blood film evaluation to do that. So blood film evaluation is very important in cases of inflammation. So again, this is just one more example. This is a patient with pyometra. The first leukogram was taken before surgery, and the second leukogram was taken 24 hours after surgery. So in our second leukogram, again, our leukogram is still not great. We still have significant inflammation. We still have a degenerative left shift, but at the very least, we do see improvements. So our total leukocyte count and our total neutrophil count has increased. We have a decrease in the degree of our left shift, and we also have a decrease in the amount of toxic change present. So, even though our leukogram picture is not fantastic, we're still trending in the right direction. And if we were kind of continuing to take serial CBCs over time, we would expect to see continued improvements in that leukogram. Okay. So just moving through some species-specific differences to keep in mind when you're interpreting your leukogram. So Dogs have the largest neutrophil storage pool in the bone marrow of our kind of common veterinary species. And because of that, they can achieve very large elevations in their neutrophil counts. So a leukocyte count of up to 100 is possible, but it is very rare for it to happen. Cats, they still can achieve quite high neutrophil counts, but probably not to the quite as big as dogs can. But they have the largest marginating neutrophil pool or marginating leukocyte pool present, and that's why physiological leukocytoses are more commonly identified in cats. Low numbers of Dolly bodies can be seen in feline neutrophils as a normal finding, so just be careful not to overinterpret those too much. And giant neutrophils can be seen with inflammation, as I mentioned before. So for horses, your leukogram changes in horses can be quite a lot more subtle than they are in dogs and cats. You often don't see a particularly severe leukocytosis or neutrophilia, and left shifts are fairly uncommon as well. So even a mild neutrophilia in a horse can indicate quite significant inflammation. And if you have established inflammation or an appropriate bone marrow response, your neutrophil count can pretty easily be within reference interval. So it can be difficult to demonstrate the presence of inflammation in horses just with a white cell count or a leukogram, and this is where acute phase proteins really come in handy. And again, a physiological leukocytosis is something to consider in young horses. Moving on to ruminants. So ruminants in general, they have a much smaller storage pool of neutrophils than other species, particularly in comparison to dogs and cats. This means that with acute inflammation, before the bone marrow has really kind of had time to respond and increase production, this storage pool gets depleted very quickly. And because of that, it's pretty common to see a neutropenia occurring with acute inflammation in our ruminants. So in dogs and cats, you know, we see a neutropenia and get worried that we have kind of very severe, kind of overwhelming inflammation. In ruminants, we're still concerned, but it's almost an expected finding that it happens. And this is where monitoring trends can be quite important, as we want to see that neutropenia resolve as that bone marrow production improves. But in saying that, even when you have established inflammation and you have that bone marrow response, total leukocyte counts tend to be fairly low in comparison and kind of similar to horses. So in ruminants, similar to horses, kind of a leukocyte count of even 20 to 30 is considered quite markedly elevated. And again, because of those fairly subtle changes, that's where acute phase proteins can be helpful. So I'm just going to touch on some other changes in the CBC and our biochem panels that we can see associated with inflammation. So probably the main ones on our erythrogram and our thymogram. So with our erythrogram, an anemia of inflammatory disease is something we can quite commonly see, and is related to transferrin or iron sequestration in the body in response to inflammation. You may see a decreased MCV if there is prolonged inflammation, and it can kind of almost mimic a developing iron deficiency, but that's relatively uncommon. And typically the anemia is normocytic and normochromic. And because it's a controlled, it's a fairly controlled process by the body. So the anemia tends to be mild to moderate and doesn't progress unless you have other causes of anemia that are contributing concurrently. And then for our thrombogram, a thrombocytosis is very commonly seen with inflammation as well. Basically, inflammatory cytokines that stimulate, mediate inflammation, they can also stimulate platelet production. As far as biochemistry changes with inflammation go, probably I guess the main thing you might be familiar with is an acute phase protein response, which you can see reflected in albumin and globulin values. So albumin is a negative acute phase protein. Hepatocytes downregulate albumin production when inflammation is occurring, and tends to only cause a mild hypoalbuminemia unless you have concurrent albumin losses occurring somewhere else. The half-life of albumin does vary a bit between species. So for example, in dogs, it's around a week, and in horses, it's around 3 weeks. So because the half-life of albumin in horses is longer, a hypoalbuminemia secondary to inflammation is going to take longer to develop in a horse compared to a dog. But in all species, it's pretty much going to take at least a few days. So, even though we kind of call it an acute phase protein response, it takes a few days to develop. And because of that, it's a fairly insensitive marker of inflammation, or your inflammation has to be present for a few days before you see it. Similarly, a hyperglobulinemia might be seen with inflammation, and immunoglobulin production generally takes about 1 to 3 weeks after the onset of inflammation. So similar to changes in albumin, changes in globulins take time. A couple other maybe less common changes that you don't always see, but are good to keep in mind. One is a hyperbilirubinemia. This can develop as a result of functional cholestasis, secondary to inflammation. And this is generally mediated by either cytokines or particularly bacterial endotoxins. So in cases of endotoxemia or sepsis. But basically these cytokines and endotoxin, they can downregulate bile transporters. And this results in decreased bilirubin excretion, which therefore results in a hyperbilirubinemia. And this can occur without significant elevations in ALP or GGT, which I guess they're the enzymes that we associate with cholestasis otherwise. And a hypocalcemia has also been seen associated with critical illness cases of sepsis in dogs and cats, but the exact mechanism is not fully known. Okay, so moving on to our acute phase proteins. So our acute phase proteins are part of the innate immune system. So they're kind of a fairly primitive part of the body's kind of inflammation system. And they increase very rapidly in response to inflammation. So they're almost like your first line of defense. So they're defined as proteins that change in concentration by more than 25% in response to inflammatory cytokines. They're produced rapidly in response to inflammation. So kind of hours after insult, you can see increases in acute phase proteins. And peak concentrations can be reached within a day or two, and then levels can either decline very rapidly or over a period of days after that inflammatory stimulus is withdrawn or resolved. So they're considered a very sensitive marker of inflammation. So, if you have cases where your leukogram findings are sort of inconclusive or borderline, and you're wondering if there's inflammation occurring or not, that's where your acute phase proteins can really be beneficial. So they can detect the presence of inflammation where maybe your leukogram does not. But similar to leukogram changes, while acute phase proteins are sensitive, they're non-specific as to the cause of inflammation. So, infectious, non-infectious causes, more localized or more systemic inflammation, trauma, immune-mediated disease, neoplasia, any cause of inflammation will increase your acute phase protein concentrations. So fibrinogen is probably the most commonly used acute phase protein at the moment, or maybe is the one that people are most familiar with. It's typically mostly been used as a marker of inflammation in horses and ruminants. Given the difficulties in interpreting their leukograms, as I mentioned previously. So fibrinogen production increases in response to inflammation and is itself an acute phase protein. One of the problems you can see with interpreting fibrinogen is the non-inflammatory causes that can affect fibrinogen concentration. So increases in fibrinogen can be seen with dehydration. And one of the other issues is that fibrinogen can be consumed in the body when there is coagulation occurring, sort of either locally or systemically, like with DIC. And I guess like some degree of coagulation is a relatively common thing that you'll see when there is inflammation as well. So basically, you know, there are significant external factors that can influence fibrinogen concentrations, but these factors that influence fibrinogen don't really influence the concentrations of our other acute phase proteins. So our other acute phase proteins, particularly SAA and CRP, they're considered our more sensitive markers of inflammation, even in comparison to fibrinogen. So moving on to CRP, or C-reactive protein, this is the major acute phase protein of dogs. You get marked increases in response to acute inflammation, and the inflammation can be systemic or more localized. A couple non-inflammatory causes of increased CRP to keep in mind. One, CRP is expected to increase during pregnancy. And we have seen kind of dogs with renal disease can have relatively mild increases in CRP as well. So CRP has been investigated in relation to both sort of, again, more acute systemic inflammation as well as more localized infections too. So this was a study that looked at dogs with systemic inflammatory response syndrome, or sepsis. So basically serious systemic inflammation. And the main things they found in this study is CRP levels at admission to the hospital did not necessarily discriminate between survivors and non-survivors. And so, for example, a dog at admission with a CRP level of 200 doesn't necessarily have a worse prognosis than a dog with a CRP of 100 at admission. But what they found was that if they monitored these dogs over even a fairly short time frame, so like they monitor these dogs over 48 hours, even after that amount of time, they started to see differences in the CRP concentrations between survivors and non-survivors. So in those survivors, they tended to see that CRP levels were decreasing over time, indicating that basically their treatments or their interventions were kind of getting on top of their inflammation. Whereas in dogs where their CRP levels were sort of unchanged or increasing, potentially those dogs carried a worse prognosis. Moving on to, so CRP has also been looked at in cases of more localized inflammatory conditions. So one study looked at measuring C-reactive protein in dogs with discospondylitis. So this was a study involving 16 dogs. So of these 16 cases, 14 of them had a documented increase in C-reactive protein, whereas only 6 of those dogs had a leukocytosis. So again, that kind of shows that CRP can be useful at documenting inflammation, or being a bit more of a sensitive marker of inflammation. Then when they treated these dogs, they repeated CRP measurements 4 and 6 weeks after they started antimicrobial treatment, and they found that CRP levels have normalized in all cases. So you can almost use it as a marker of how effective your treatment is in the long term as well. In somewhat of a similar vein, CRP was also measured in dogs with steroid-responsive meningitis and arteritis. And in this study, they found that decreases in serum CRP levels somewhat mirrored decreases in CSF cell count. So kind of indicating that as these dogs were treated and inflammation resolved, CRP levels decreased as a result. So I guess just going to show that CRP can be useful as a monitoring tool for both acute and chronic inflammation in dogs. These are the current guidelines we have for interpreting CRP concentrations in dogs. Just to mention that we have had some supply issues around our CRP and SAA reagents in the last few months, and we may be changing our SAA reagent in the near future in particular as well. So these guidelines may be changing, but yeah, we'll let you know if they do. And then I guess the other thing to mention is just be careful interpreting the numbers too literally. So, you know, a dog with a CRP of 200 doesn't necessarily have twice as much inflammation as another dog with a CRP of 100. More where the value is sort of those kind of broadly categorizing, you know, if inflammation is present or not. And you can, again, broadly categorize how severe it is, but looking at trends in between, like in your individual patients, that's where differences in the numbers can be useful. So moving on to serum amyloid A, this is the major acute phase protein of pretty much all of our other veterinary species. Non-inflammatory causes of SAA to consider. In horses, increases are documented with endurance riding or straight after strenuous exercise. This may not strictly be non-inflammatory, as you know, that amount of exercise probably causes some level of inflammation. Just keep in mind that an increased SAA would almost be an expected finding in this situation. And also very young foals, you know, even just a few days of age up to a week of age, they can have increased SAA levels, even though they seem clinically healthy. So just take care when you're interpreting SAA levels in very young foals. And in cats, increases in SAA have been documented with various sort of non-inflammatory conditions. So hypothyroidism, diabetes, and renal disease are the main three. So again, just something to keep in mind. So similar to CRP in dogs, SAA in cats has been investigated in a variety of conditions. SAA, or significant increases in SAA, have been found in a wide variety of conditions. So including more localized inflammatory processes like upper respiratory tract infections, and more systemic disease like pneumonia, FIP, or pyometra. The data on using SAA as a prognostic marker is pretty inconsistent. So some studies have shown that sort of single SAA levels at admission may be somewhat associated with prognosis, but other studies haven't documented that link. Generally speaking, it again is probably similar to CRP in dogs in that SAA may have prognostic use in emergency or critical care cases, but the most usefulness you're going to have is by taking serial measurements over time and documenting how your acute phase proteins are changing over time, which gives you an idea as to is your inflammation, you know, resolving, worsening, or staying the same. So this was a case report that looked at SAA levels with more chronic disease. Now, this is a single cat, so I guess we've got to be a little bit careful in extrapolating too much from a single case. But this was a cat that had histologically diagnosed pancreatitis. On day 5 and day 23 post-diagnosis, the patient was noted to be clinically improved, and at that time, serum amyloid A levels were within normal limits, though there was still a neutrophilia present. And then conversely, at days 310 and day 405, there was an occurrence of clinical signs, so the cat appeared clinically unwell. At that time, serum amyloid A concentrations were increased, but white blood cell counts were not. So it was suggested that sort of these, the changes in SAA concentrations seem to mirror changes in the clinical condition of this cat better than the leukogram did. So if you were just using the leukogram to monitor this patient, you were potentially missing kind of a piece of the puzzle. These are our interpretation guides for cats. Again, they may change in the future, but typically sort of SAA increases in cats tend to be a little bit smaller than they are compared to CRP in dogs and particularly in horses. So finally, with our horses, again, serum amyloid A can be particularly useful given their kind of fairly mild leukogram changes. And again, the presence of a normal leukogram doesn't really rule out the presence of inflammation in our horses. So some particular areas where it may be useful, large increases in SAA have been seen in foals with bacterial infections. One exception seems to be that bacterial pneumonia due to Rhodococcus equi infections in farms where Rhodococcus is endemic. For whatever reason, those infections don't always seem to increase SAA levels. In respiratory disease, serum amyloid A could be useful or in helping to delineate between like infectious causes and non-infectious causes. So say differentiating between bacterial pneumonias and equine asthma. And then measuring SAA levels in equine colic cases can show similar utility to dogs with acute abdomens or emergency cases. So again, there's somewhat mixed data about SAA levels at admission. So some research shows that there may be some prognostic use to this, but similar to dogs and cats, it's likely that serial SAA measurements is of kind of greater diagnostic or prognostic significance. So again, sort of what is happening to your SAA concentrations over time. And it could also be useful post-surgery in surgical colic cases. So, you know, if your SAA concentrations are persistently elevated or even increasing after surgical intervention, that maybe there's a sign that there are complications occurring. So these are our interpretation guides for our horses. Again, they may change in the future, but even, I guess, just going to show that SAA increases in horses can be quite more pronounced than in other veterinary species. So just to summarize acute phase proteins and I guess inflammation in general. So as I mentioned before, monitoring changes over time provides the most accurate picture of the presence and potentially the magnitude of inflammation occurring in your patients. And so you can monitor these changes over time in both your leukogram and in your acute phase protein concentrations. Our acute phase proteins are generally our most sensitive markers of inflammation and can help demonstrate the presence of inflammation when leukogram changes are either not apparent or it's inconclusive, or you're not quite sure if there's inflammation present or not. So, you know, our leukogram changes may be a little bit more volatile or affected by a wider variety of factors, whereas changes in CRP or SAA or acute phase proteins may be more consistent and they may be more helpful. But I guess, as always, we want to look at our patient and not just the numbers. So make sure the changes that you're seeing in your leukogram and your acute phase proteins make sense in the context of your patient.